So today we shall learn about this arterial blood gas interpretation. So arterial blood gas interpretation, it is one of the most frequently ordered tests in the intensive care unit, and it is very essential in the management of critically ill patients. And a 24-hour ABG availability is mandatory according to the recent critical care guidelines. So the commonest sites are the radial artery and the femoral artery. So radial artery, before performing radial artery puncture, we have to perform the modified Allen's test to test the patency of the ulnar artery, and then we can go ahead with puncturing of the radial artery. So we have to use a heparin flushed syringe to collect the arterial blood in order to prevent clotting of the blood. And if there are any air bubbles, we have to remove the air bubbles, and it has to be transported immediately to the laboratory. Suppose if it takes a little more time, then we have to send the syringe in an ice pack so that the metabolism of the RBCs is minimized, so that there is a minimal alteration of PO2 and PCO2. So the normal arterial blood gas values are, the pH is around 7.36 to 7.44, PCO2 of 35 to 45 millimeter of mercury, PaO2 75 to 100 millimeter of mercury, and saturation is 93 to 99%. Bicarbonate is 22 to 26 milliequivalents per liter, and methemoglobin concentration is less than 2%, carboxyhemoglobin concentration is less than 3%, and base excess is -2 to +2 milliequivalents per liter. And the oxygen content in the arterial blood is 16 to 22 ml per deciliter. So base excess, we should know about this base excess. Base excess is defined as the amount of the acid or the alkali which has to be added to the solution or blood to bring back the pH to 7.4 at a PCO2 of 40 millimeter of mercury. So base excess, if it is minus, you tell it as a base deficit. If it is a plus, you tell it as base excess. So it is defined as the amount of the acid or the alkali which has to be added to the solution or blood to bring the pH to 7.4 at a PCO2 of 40 millimeter of mercury. So this base excess, it tells what is the metabolic component of the acid-base disorder. So suppose if you have got any mixed disorders and you cannot estimate what is the metabolic component is there or not, and in case patient is having only respiratory problem and associated metabolic acidosis also. So to assess this one, you should know this base excess. By knowing this base excess, you can calculate you can know what is the metabolic component of the acid-base disorder. Right. So with this modern ABG machines, we measure this pH, PCO2 and PO2 with the help of standard electrodes and digital analyzers. So this pH, PCO2 and PO2 and your electrolytes like sodium, potassium, chloride, calcium, all these are measured with the help of standard electrodes. This oxygen saturation, it is an indirect measurement. That is, it is calculated. That is based upon the oxygen hemoglobin dissociation curve. Say, for example, PO2 is 80 millimeter of mercury. So then for that PO2, what is the corresponding saturation? It is given by the ABG machine. If the PO2 is 60 millimeter of mercury, then the corresponding saturation around 88 to 90%, it is given by the ABG machine. So few ABG machines, they employ this co-oximeter. So with this co-oximeter, this oxygen saturation is given, and also your carboxyhemoglobin and methemoglobin concentration also can be measured. Now coming to bicarbonate. Bicarbonate, it is also an indirect measurement. That is, it is measured by this Henderson-Hasselbalch equation. So what is the 10-step approach for ABG interpretation? So always we should go methodically in order to miss any hidden disorders, and also don't jump directly into the acid-base analysis. So first step is you should assess what is the oxygenation status of the patient. Second step is assessment of the ventilation status, and third is you have got your acid-base balance. That is 8 steps are there. So the step 1. So you should know what is the normal PaO2. Normal PaO2 is around 75 to 100 millimeter of mercury. So when it is less than 75, that is 60 to 75, you call it as mild hypoxemia, and 40 to 60 as moderate hypoxemia, and less than 40 millimeter mercury as severe hypoxemia. All these values are when the patient is breathing room air. So the alveolar arterial gradient is 5 to 25 millimeter of mercury, 5 millimeter of mercury in an young adult and also fit athlete, and 25 millimeter of mercury will be in a patient with who is very sick patient and patient having obesity and patient having abdomen compartment syndrome and old age. So PaO to FiO2 ratio is more than 400, that is normal. So step 2, that is the assessment of the ventilator status of the patient. So this PaCO2 is around normal, it is 35 to 45 millimeter of mercury. When the PaCO2 is less than 35 millimeter of mercury, that means patient is hyperventilating. And if it is more than 45 millimeter of mercury, patient is hypoventilating. Okay, that means patient will be having respiratory acidosis like that. So now coming to the acid-base assessment. This acid-base assessment, it consists of 8 steps. So step 1, what is the pH? So what is the pH here? So if the pH is less than 7.35, you tell patient is having acidosis. The patient, if the pH is more than 7.45, then you tell it is alkalosis. Then step 2, what is the primary disturbance? You should know what is the primary disturbance, whether it is a metabolic or a respiratory component. So provided if the patient is pH is less than 7.35, that is acidosis, and the bicarbonate is less than 22, then you tell patient is having metabolic acidosis. If the pH is less than 7.35 and PCO2 is more than 45, then you tell the primary disorder is respiratory acidosis. Similarly, if the pH is more than 7.45, that is alkalosis, and bicarbonate more than 26, then you tell patient is having a primary metabolic alkalosis. And when pH is more than 7.45 and PCO2 is less than 35, then you tell it this patient is hyperventilating. That is why patient is having primary respiratory alkalosis. So this determination of what is the primary disturbance, it is a very important step in assessing this acid-base balance. So now this step 3, if the primary disturbance is respiratory, so we should determine whether it is an acute or chronic. So usually acute respiratory disturbance means less than 24 hours and chronic respiratory disturbance means more than 24 to 48 hours. So here, in case of acute respiratory disturbance, your pH changes by 0.07 to 0.08 units for every 10 millimeter mercury change in PCO2. So for example, take this patient here, the PCO2 is 60 millimeter of mercury. So in case of an acute respiratory acidosis, here the PCO2 has increased by 20 millimeter of mercury. So for every 10 millimeter of mercury of change in PCO2, the change in pH is 0.07 to 0.08. So here 20 it has increased. So correspondingly, so what should occur? There should be a decrease in pH by 0.16 units. So here from 7.4 it has become 7.24. So this is acute respiratory acidosis. So now when you see the case in case of chronic respiratory acidosis, that is in a patient with COPD. So here the PCO2 is 60 millimeter of mercury and pH is 7.33. So PCO2 has increased by 20 millimeter of mercury, but the change in pH is 0.7 only. That is, for every 10 millimeter of mercury of change in PCO2, your pH has changed by only 0.03 units. So this is called as chronic respiratory acidosis, usually seen in patient with COPD, that is emphysema and chronic bronchitis. So then step 4. So if the patient is having a respiratory disorder, is the renal compensation okay? So usually what will happen whenever a patient is having a respiratory acidosis? In respiratory acidosis, there is an increase in PCO2. So correspondingly, what should happen? There should be an increase in bicarbonate. That is the metabolic compensation. So you should always remember this same rule, same direction. So that is, whenever there is an increase in PCO2, there will be an increase in bicarbonate. And whenever there is a decrease in PCO2, the bicarbonate also has to decrease. That is same direction rule. They both have to move in the same direction. If it is a simple acid-base disorder, if it is a mixed acid-base disorder, then one increases, then another decreases, that means it is a mixed respiratory and also metabolic disorder. So in case of acute respiratory acidosis, so here what will happen? The bicarbonate increases by only 1 milliequivalent per liter for every 10 millimeter mercury increase in PCO2. So if the PCO2 increases by 10 millimeter mercury, so your bicarbonate increases by only 1 milliequivalents per liter. And in case of chronic respiratory acidosis, when the PCO2 increases by 10 millimeter of mercury, your bicarbonate it increases by only 3 to 4 milliequivalents per liter. So, and in case of a chronic, in case of respiratory alkalosis, when in acute respiratory alkalosis, what happens? There is a decrease in PCO2. So whenever there is a decrease in PCO2, the bicarbonate also has to decrease. So this bicarbonate decreases by 2 milliequivalents per liter for every 10 millimeter mercury decrease in PCO2. Okay, and then in case of chronic respiratory alkalosis, what will happen? In a respiratory alkalosis, there is a decrease in PCO2. Corresponding to the decrease in PCO2, there should be a decrease in bicarbonate also. Here, the decrease in bicarbonate is much more, because by that time the renal compensation has started. That is why this acute and chronic concept is there. So in case of acute, that is less than 24 hours, the renal compensation is not adequate. That is why the change in bicarbonate is very less in case of acute respiratory acidosis and also acute respiratory alkalosis. In case of chronic, that is whenever the duration is more than 24 to 48 hours, the renal compensation comes into picture. That is why the increase or the decrease in bicarbonate, it is more for a given change in PCO2. So now step 5, that is, if the disturbance is metabolic, is the respiratory compensation appropriate? So for example, if the patient is having a primary metabolic disorder, then we should know whether the respiratory compensation is adequate or not. So in case of primary metabolic acidosis, so what will happen in case of metabolic acidosis? There is a decrease in bicarbonate. So, but there is a decrease in bicarbonate, for which what has to happen compensatorily, there should be a decrease in PCO2. That means patient has to hyperventilate. There will be hyperventilation in that patient. So how do you know whether this patient is hyperventilating appropriately or not? So you should know what is this Winter's equation. So expected PCO2 in a patient with metabolic acidosis, it will be equal to 1.5 times the bicarbonate plus 8. So for example, in a patient who is having diabetic ketoacidosis, if the bicarbonate is 8 milliequivalents per liter, then the expected PCO2, that means if the so much of acidosis is there, patient will be hyperventilating. So with that hyperventilation, there will be a drop in PCO2. So then the expected PCO2 will be 1.5 times bicarbonate, that is 1.5 into 8 is equal to, that is 12 plus 8 is equal to 12 plus 8 is equal to 20 millimeter mercury. PCO2 is equal to 20 millimeter mercury plus or minus 2. That is in case of metabolic acidosis. Now coming to, if the primary disorder is metabolic alkalosis. So in metabolic alkalosis, what will happen? There is an increase in bicarbonate. So correspondingly, there should be an increase in PCO2. That is a normal compensation. That is a compensation which occurs. Okay. So here, the expected PCO2, here the expected PCO2 should be 0.7 times the bicarbonate plus 21. So here, for example, if the bicarbonate is equal to 30, then expected PCO2 is equal to 0.7 into bicarbonate, that is 21. That is 21 plus 21, that is 42 plus or minus 1.5 means that is approximately equal to 44 millimeter of mercury. So by knowing this in this step 5, we know what is the expected compensation if the patient is having a primary metabolic disorder. So if the patient is having metabolic acidosis, then we should also calculate what is known as anion gap. So what exactly is anion gap? Anion gap is given by the formula anion gap is equal to sodium minus chloride plus bicarbonate. The normal value is usually 7 to 14 milliequivalents per liter. It is actually the difference between the unmeasured anions and the unmeasured cations. So these are all the difference between these two. It gives the anion gap. For example, the unmeasured anions are the proteins, that is mostly albumin, 15 milliequivalents per liter, and organic acids, phosphates, and sulfates, because these all we don't measure. And unmeasured cations, that is calcium, potassium, and magnesium. These are all positively charged and these are all negatively charged. So these unmeasured anions are in excess of the unmeasured cations. So this results in what is known as this anion gap. Ideally, in human physiology, normally what will be there is, in any disorder, the sum of all the positive ions, that is cations, and the sum of all the negative ions will be equal. So that is called as electroneutrality. So here, in case of anion gap, what we are doing is we are taking a shortcut. It is something like a shortcut. That is, we are taking the difference between sodium minus chloride plus bicarbonate, because sodium represents most of the cations which are present in the blood, because it is a major contributor for the cations which is present in the blood. And similarly, this chloride and bicarbonate also contribute for the majority of the unmeasured majority of the anions in the blood. So the same thing here. Anion gap is the difference between sodium and chloride bicarbonate. So here you should remember this concept of electroneutrality, that is the sum of all the positive ions, that is cations, and the sum of all the negative ions, it should be equal. So that is called as electroneutrality. So now coming to what are the causes for high anion gap metabolic acidosis and normal anion gap metabolic acidosis. This normal anion gap metabolic acidosis. So whenever there is an excessive infusion of sodium chloride, that is normal saline, so that results in hyperchloremic metabolic acidosis. And also in case of loss of bicarbonate through the GIT, in case of diarrhea. So here what happens in case of diarrheic patients, there is loss of bicarbonate. Whenever there is loss of this bicarbonate, what will the body compensate? The body compensates by retaining the chloride. So there is a chloride retention will be there. So this leads to what happens? The difference between these two will be normal. So this is called as normal anion gap metabolic acidosis. So whenever there is a bicarbonate loss through the GIT in case of diarrhea, so there will be a compensatory this chloride retention in order to maintain this electroneutrality. So the sum of chloride and bicarbonate will be normal. So this leads to the normal anion gap metabolic acidosis. Okay. So, and also the other cause for normal anion gap metabolic acidosis is renal tubular acidosis. So whenever the anion gap is more than 14, so then you call it as increased anion gap metabolic acidosis. So this increased anion gap metabolic acidosis, they are seen in a variety of conditions. That is, the mnemonic is mud pies, that is methyl alcohol poisoning, uremia, that is renal failure, diabetic ketoacidosis, a paraldehyde infection, that is lactic acidosis, ethylene glycol, and also salicylate poisoning. So in all these conditions, there is an increase in anion gap. There is increased anion gap metabolic acidosis is seen in all these cases. Okay. So now we should know what is known as this albumin corrected anion gap. So if the patient, so as we have known in the previous slide here, that the proteins, unmeasured anions, the proteins that is mostly albumin, it contributes to this unmeasured anions. So in patients with hypoalbuminemia, what happens is there is an error when you estimate this anion gap. So it will not be the normal anion gap. So you have to do some correction. So this is called as albumin corrected anion gap. So because 3/4 of the normal anion gap consists of the albumin, so the calculated anion gap should be corrected for hypoalbuminemia. So how this correction is done is albumin corrected anion gap is equal to anion gap plus the normal serum albumin minus the measured albumin into 2. Okay. So say for example, patient's serum albumin is 2 grams per deciliter. So when compared to the normal of 4 grams per deciliter. So now the albumin correct and this anion gap in this patient is say 13 milliequivalents per liter. So now albumin corrected anion gap in this patient is equal to, that is anion gap plus your 4, that is normal serum albumin minus the actual in this patient, what is the serum albumin? It is 2 into 2. So that is 13 plus 2 into 2 is 4. So 13 plus 4 is equal to 17 milliequivalents per liter. So in this patient, so the albumin corrected anion gap is equal to 17 milliequivalents per liter. So when you don't do this albumin corrected anion gap, so by just seeing this anion gap, it is, if it is 13, then you tell it is a normal anion gap metabolic acidosis. So when you do this albumin correction, then you get to know that patient is having increased anion gap metabolic acidosis. So your entire diagnosis will change. That is why this you have to remember this albumin corrected anion gap. So now step 7. So in this step 7 here you have got what is known as this delta ratio. So in this delta ratio, you should know what is this delta ratio. Delta ratio, it is defined as the ratio of the, that is a delta anion gap to delta bicarbonate. So delta ratio is equal to measured anion gap minus normal anion gap divided by 24 minus measured bicarbonate. Okay. So by knowing this delta ratio, we can diagnose whether there are any hidden disorders in this patient. That is not hidden, it is basically mixed acid disorders we can diagnose in a patient. So if the delta ratio is 1 to 2, then you tell patient is having uncomplicated high anion gap acidosis. If it is more than 2, it is more than 2. Why this more than 2 occurs means because in this denominator it has decreased. Why this denominator has decreased means because the measured bicarbonate has increased. So this difference has decreased. Why this measured bicarbonate has increased means that is because of the additional metabolic alkalosis. So it gives high anion gap metabolic acidosis and concurrent metabolic alkalosis. So whenever this delta ratio is less than 0.4, then it is hyperchloremic normal anion gap acidosis. And when it is 0.4 to 0.8, then you have to consider high anion gap acidosis and normal anion gap acidosis. Okay. So this delta ratio, by doing the delta ratio, we can know any other mixed disorders are there or not in this patient. So next is step 8. So next is step 8. Are the clinical data consistent with the proposed interpretation? So always analyze all these data in relation to the clinical condition of the patient. Just don't see the ABG, whatever the slip, and do the diagnosis and everything. So always try to correlate clinically with the patient's condition so that it will be accurate. So now here there is an example case study. A 30-year-old man is admitted in the emergency room for severe breathlessness. His respiratory rate is 36 per minute and he is using accessory breathing muscles. So these are all the values which are given for us. FiO2 of 0.9, the pH is 7.29, PCO2 is 55 millimeter of mercury, PO2 is 47 millimeter mercury, saturation is 86%, the sodium is 154, potassium is 4.1, and chloride 100, and bicarbonate is 23. So in this patient, so first what are all the steps in analyzing the ABG? So first step is assessing the oxygenation status of the patient. So when you assess the oxygenation status of the patient, what is there in this patient? This patient is having a PO2 of 47 millimeter of mercury, which is patient is having hypoxemia. The two with an FiO2 of 90%, that is the 0.9. That is your PaO to FiO2 ratio, it is less than 100. So that means patient is having severe hypoxemia. Okay, and also saturation is 86% in spite of all this 190% of oxygen. So the patient is having severe hypoxemia. So next, coming to what is the step 2, that is ventilation. So coming in this ventilation, the patient PCO2 is 55 millimeter of mercury. 55 millimeter of mercury, that is this more than 45 millimeter of mercury, upper limit of normal. That means patient is hypoventilating. So that means patient is having a respiratory acidosis. So here patient's respiratory rate is 36 per minute, and also he is using axillary breathing muscle. So in spite of this respiratory rate of 36 per minute and patient also using axillary breathing muscles, patient is having a PCO2 of 55 millimeter of mercury. This indicates a patient is having patient is going into respiratory, he is having a type 2 respiratory failure. Initially it might have started with a type 1 respiratory failure, then later it has progressed to type 2 respiratory failure because there is a hypercarbia, patient is hypoventilating. So here, as I told you, step 1, oxygenation, the PaO2 and SaO2 are both markedly reduced on 90% inspire oxygen, indicating severe ventilation perfusion imbalance, and PaO2 FiO2 ratio is less than 100. So sorry, in this it is not 100 millimeter of mercury, it is the ratio, that's all. Okay, so it is given as a ratio, and there is an impaired oxygenation is there. In case of step 2, this ventilation, the PCO2 is 55 millimeter of mercury, indicating patient is hypoventilating. Despite patient having tachypnea and also axillary muscles being used, PCO2 is 55 millimeter of mercury, indicating a lot of dead space ventilation, and also patient needs mechanical ventilation. So that means patient is hypoventilating. So now coming to the assessment of acid-base balance. This assessment of acid-base balance, the pH is 7.29. The patient is having acidosis, and the PCO2 is 55 millimeter of mercury, and that means patient is having respiratory acidosis. And here bicarbonate is 23 millimeter of mercury. We have to see whether there is any compensation is there or not. Okay, so in this patient, the history is not given whether it is an acute history or it's a chronic history. So less than 24 hours or more than 24 to 48 hours history, we don't know. So because it is not given, and also patient is admitted in the emergency room with severe breathlessness, we consider it as patient is having presented with an acute disease. So it is taken as acute respiratory acidosis. So here acute respiratory acidosis, here what should happen in case of acute respiratory acidosis? The PCO2 it has increased. So and your pH is decreased. So here when there is a 15 millimeter of mercury of this increase in PCO2. So what should happen? Your pH it has to decrease by 0.07 to 0.08 units per 10 millimeter of mercury rise in PCO2. So it is coming to almost like same thing. So it should be around 7.28. So it is around when you take a normal of average pH of 7.4. So your pH should have been 7.28. It is somewhere coming around to 7.29. Okay. So now coming to this bicarbonate. So this bicarbonate here, the PCO2 has increased, and bicarbonate it is 23 milliequivalents per liter. So here bicarbonate, we cannot comment much upon bicarbonate here because bicarbonate it is normal. It is within the normal range of 22 to 26 milliequivalents per liter. Okay. So in this step 1, the pH is less than 7.35, that is patient is having acidosis. And step 2, it is the primary disturbance is respiratory or metabolic, means since the PCO2 is more than 45, you tell it as primary patient is having a respiratory acidosis. And step 3 is the respiratory disturbance, acute or chronic. So For 11 millimeter increase in PCO2, pH is decreased by 0.11 units, as I told previously. So it is an acute respiratory acidosis. So step 4 is the metabolic compensation appropriate. So given this acute respiratory acidosis, for 11 millimeter mercury increase in PCO2, there should be 1 milliequivalent rise in bicarbonate. So we cannot comment much about this metabolic compensation in this patient as of now, because it is within the normal range of 22 to 26. So now coming to in this, because we don't know what is the metabolic disorder in this patient, we cannot comment about the step 5 also. Now coming to step 6, that is what is the anion gap in this patient. The anion gap, that is sodium minus chloride plus bicarbonate. So anion gap is 35 milliequivalents per liter. That means increased anion gap is there in this patient. Increased anion gap is there in this patient. So patient will be having mostly an increased anion gap, metabolic acidosis is there. So now coming to step 7, that is delta ratio. Delta ratio is defined as ratio of delta anion gap to delta bicarbonate. That is change in anion gap to change in bicarbonate. That is equal to, so your delta ratio, there is anion gap is 35 minus normal anion gap is 14 divided by change in bicarbonate. That is normal bicarbonate is 24 minus actual patient bicarbonate is 23. So here we have got a value of around 20. So this delta ratio is 20. If it is more than 20, then it indicates, if it is more than 2, then it indicates a combined high anion gap metabolic acidosis and also metabolic alkalosis. So this metabolic alkalosis, how we can say metabolic alkalosis? Because actually this whatever this for this anion gap, your bicarbonate should have been much less. If it is a pure metabolic acidosis, so this should have been much less, but the bicarbonate is increased. It is increased up to 23. So this indicates there is a hidden metabolic alkalosis also in this patient. So by seeing this delta ratio, we can diagnose metabolic alkalosis also in this patient. So step 8. So do these clinical data correlate with the proposed interpretation? So do this. So increased anion gap metabolic acidosis can be explained by hypoxemia. So because this hypoxemia can lead to anaerobic metabolism and lactic acidosis, so this increased anion gap metabolic acidosis can be explained. And the reason for metabolic alkalosis has to be determined. We don't know for what reason this bicarbonate is increased. Whether because of this metabolic acidosis, they have given soda bicarb has been given, sodium bicarbonate has been given to the patient or not, we don't know by the history. So that may be one of the reason for the metabolic alkalosis. Okay. So this patient is having, so what is the diagnosis or the interpretation of ABG in this patient? Patient is having impaired oxygenation. That is number 1. Impaired oxygenation, that is severe hypoxemia, wherein PaO2 to FiO2 ratio is less than 100, and patient is hypoventilating, that is PCO2 is 55 millimeter of mercury, that is patient is having type 2 respiratory failure. And acid-base disturbance interpretation is patient is having acute respiratory acidosis and high anion gap metabolic acidosis and metabolic alkalosis. Okay. So this is the complete interpretation of ABG in this patient. Likewise, you can take any number of examples of ABGs which are available in your hospital and take this stepwise approach. There is this 10-step approach for ABG interpretation. Okay. Thank you.